Shahir Kassam-Adams is one of the most knowledgeable and outspoken people in healthcare. In this episode of Health Biz, Shahir shares his initially unsettling but ultimately reassuring view that data will eat public health. He opines on interoperability and explains how his company, Datavant, has promoted data sharing on COVID-19, leading to a plethora of interesting and potentially useful projects, including one that models the tradeoffs for specific American cities to reopen. I'm your host, David Williams. Listen in, and you'll soon understand why Shahir is one of my favorites. Well, Shahir, it's nice to finally have you on the Health Biz podcast. What took you so long?
Well, you never invited me.
Well, you got to know there's a secret way in, but I'm glad that I did. So, Shahir, I've known you for quite a while, but not everybody knows exactly who you are. So, what's your basic background? Give me the sketch.
Well, that'll take up the whole podcast right there. So, let's do the short version. Well, I'm a first-generation Asian Indian, born in East Africa.
Yeah.
Tanzania, actually, and grew up in Atlanta. I was 12 when I moved there. I met my wife, Nancy, which is where the Adams part of the name came in, when we were 17, and we just celebrated 40 years of 40th anniversary.
Outstanding. Well, my math isn't too good, so that means you're at least over 40 now, I think.
I'm 61.
Boy.
I'm listen, when you're 61 and you can still call yourself a healthcare tech entrepreneur, you've either hid really well or you're surviving. So it's okay.
Now, Shahir, Tanzania is my specialty because there's a company I'm the chair of the advisory board for, Medulin, and the CEO's from Tanzania as well. So what are the chances?
Well, I bet you I know the guy because, it's such a very small country of 50 million people. We know everybody. So.
Yeah. Sounds good. All right. So you basically hit your high point at 17, like many of us. And so what are you working on now?
Well, this is kind of a really interesting thing. I'm most excited and most proud of, actually, something we're doing related to COVID. You're probably tired of hearing about COVID, but I just refer
to COVID in the past tense. I find that takes care of it.
I wish. Would be good. Having not had it yet, I'm trying to avoid it, so I don't want it to be in the future tense for sure. Listen, what I'm involved in is with a bunch of my colleagues at Datavant, we sort of, in April, it became pretty clear to us that this pandemic was going to need a lot of sort of an urgent search for information. And the public health institutions that were responsible for some of that data were under a lot of pressure for operational data, and sadly, were getting very politicized. So the data that was going to be needed by the research enterprise, the folks who actually think about how are we going to do something, what should be the long-term view of something, who's getting affected, all that data was not getting to those folks. And because of the way we were working, it became pretty clear to us that, look, some of that data, candidly, didn't have to wait for those public institutions to get out, because a lot of commercial organizations and hospitals and others, not-for-profits, had a lot of that data. And we were already working with many of them. So we kind of gathered up a bunch of folks, about a dozen so, and we said, listen, let's see if we can put together something that would be free if it was limited to COVID research and it was available to all policy and medical research community folks. And we quickly put that together. We now have over 30 data and technology partners who are providing a free database of real-world data about COVID to policy and public health researchers. And what we've done there is really one of the critical and uncompromising components of this is patient privacy preservation. And we're using the Datavant software to make sure the privacy is protected. And we've put very tight governance processes around it. And it's the technology is managed by technology partner Medidata Solutions. And the governance is managed by a top-notch organization that's been doing it for a while, HCCI. And we have a HIPAA expert certifier who is always looking at every study, looking at every result to make sure that nothing's violating privacy. It's been a fun ride.
Sounds pretty good. So Shahir, back in April when you were dreaming this up, I was putting together some predictions about what was going to happen for the next phase. I just happened to find a crystal ball sitting on my desk, and rather than smashing it, I decided to have a look at it. And you were one of those that sort of clouded things for me because I sent you my predictions, and I had these four predictions at the time. I added five, and I sent it to a bunch of people. You were the only one that noticed that I actually had them out of order. So thanks for that. Um, but one of the predictions was about, I said public health. And I said, if you look at public health after COVID-19, it's going to be like what security was like after 9/11, really just sort of becoming pervasive. And you had a different take on it. You were talking about data, and you said that data was going to eat public health. And I still don't know what the heck you were talking about.
Well, first about 9/11 and sort of what happened there. I will say that I think one of the most important things that came out of 9/11, other than the consensus that, look, we had to tighten up on security and things like that, and that happened. But what was happening behind the scenes in all that was that part of the way that we decided as a country to protect security, you can argue about the personal freedoms, and certainly there have been a lot of arguments about it, but a large volume of data was collected so that people could understand what were the threats, who were the people who were real threats versus fake threats or mistaken threats. How are they going to manifest themselves? And you've got to admit that over the last 27 years, we've been kept reasonably safe inside our country, and that a lot of that has to come out of the fact that this large volume of data was being processed and understood all the time. We've given up something, which is some of our privacy, but at the same time, we've gotten a lot of safety, and there's been this consensus around it. Well, my argument to you back then, and I think it still is, and it holds I feel even more stronger about it, is that what is happening in healthcare and what is happening in particular in public health is that data is starting to take over for what it was that public health used to do manually. Information technology is starting to impact it. Public health has always been an information business or an information process. What they ask about is what causes a health issue? What are the causes and what are the treatment plans that are possible? What are the rates? And then in an operational sense, they say, okay, who's got it? Who's going to get it because who have they contacted? Who have they been in contact with? And then how are we going to get to those people, et cetera? So if you think about it, almost everything about the public health enterprise, everything from the planning and understanding the disease to how to treat it, all that is information-based. Now, if you think about what's been going on after the ACA, Obamacare, and the emergence of electronic medical records, the automation of how patient billing has been going on, all that data is now somewhere out in the public domain. It's out there. It's held in little silos because healthcare is fragmented. But if you could actually put all that stuff together, the power of that information is going to either eat public health and make new public health professionals out of information tech professionals, or public health professionals will step up and become information giants. So essentially, data is going to eat public health or become public health.
Well, Shahir, I think it could track some of your career as a software guy, because I think that's coming from software is going to eat the world. But there's a lot of snacks being had out there. I think the comparison, with 9/11 is interesting, and some of it actually matches up with concerns about like how do you make sure you're looking at the right person. So somebody like me who has a common first name and a common last name, often gets mixed around with data from different people. And I'm guessing that you probably have less of that going on with a longer and more unusual name, at least in this. I think it's an unusual name in any country if you look at your last name.
Well, that was sort of one of the requirements, that it had to be so unique that it could be only one of me. So that some of my friends sort of say, I'm the only guy who can get away with, almost one name, like sort of like
Yeah. That'd be perfect if you moved to Indonesia or something like that. You'll be able to do it. Not sure it'll all fit on the on your card, but nonetheless, when we talk about the data for security, a lot of it by necessity is hidden, and there hasn't been a real public debate about it. And you don't have a chance to go and correct your file and say that's a different David Williams, or that doesn't add up. Healthcare, you should. But I'm not sure in practice we've had that much of a chance to do that. And I do worry about, to the extent that there's this healthcare data out there about me, is it the right data? And I think that there's no reason I shouldn't be able to kind of control that data and be able to at least to correct it. I mean, how does the analogy go kind of beyond initially what you said about the data for security versus health?
So in healthcare, there's this really nice demarcation that happens that I think it's really important to bring out or make explicit. The first demarcation is there's data around what is needed for care. And that is the data that the physician, the nurse, the healthcare providers, the pharmacists can see in front of them. And that data has your name, David, in it. And this is why when you go to the pharmacy, they ask you what's your date of birth, because they want to make sure that at least they remove the chances that David Williams born. When were you born anyway, David?
Let's call it mid to late 60s.
Right. So let's lie and say July 12th, 1967, right? Or something
You're
like
3 days off.
There you go.
You're 3 days late.
All right. So somewhere in there, you go in and you give that date and they sort of look at it. And occasionally, if they have a conflict, they'll ask you, well, where do you live? And they'll get to the right person. But there's a human being sitting in front of you and asking you those questions and verifying it. And then care is delivered to you. But when you get to the second part of where this information becomes a problem inside care also, is you get your care in one place and then you go to a totally different place and they don't have that record. And that's become a real issue about how do you not just know it's the right person, but that the right person's data is getting to you from somewhere else. Now a computer is talking to a computer because it's going out there and saying, I need the data for David Williams born on such and such a date. But it's asking another computer, and that other computer doesn't have a way to say, well, I have three of them. Which one are you talking about? Because it may only know one David Williams. It may know the wrong one. So suddenly the wrong data is coming. So I think some of the interoperability in the clinical care setting needs to be fully fleshed out and thought through. And there are some smart people working on that. But let me shift a little bit, if I can, to the second part of where healthcare data comes in. And that healthcare data has to do with when you're getting past just taking care of David or taking care of Shahir, and you're talking about people who are in their late 50s, early 60s, who have different kinds of chronic diseases, you don't want to just look at one person's record. You want to be able to look at 60, 100, 7,000, 10,000, 100,000 people with that same problem so you can see what made a difference. Like, in the case of COVID, you really couldn't say, oh, 5 people got cured one way. Well, 500,000 may have been cured a different way. You want to make sure that you get the full-blown picture, if you will. And in that situation, you still want to make sure you get the right people's data put together, but you have another layer of problems. You want to add on top of that, you want to make sure that that person's data is still held private, even though you've put it together with a lot of other people's data. So the challenge becomes, how do you anonymize the person and preserve their privacy, but still link it up properly? And that's where we at Datavant have really been focused on it. That's the problem that got me started with founding Universal Patient Key, UPK, which became Datavant 2 years ago when it got acquired. And that's the problem we're tackling, which is how do you take large volumes of data from many different places, put it together, still make sure that it's the right person, and then still protect the person's privacy.
So Shahir, let's talk a little bit about what that would look like in a particular instance, maybe the kinds of data that are put together, how you do it. I understand using something called tokens. I thought those things were retired. I used to have those when I used to go like in the New Hampshire Turnpike or go to like the arcade, and now it's all electronic, but you're still using tokens. What are these tokens, and what are the different sort of data that you would bring together for what purpose?
Well, tokens are actually a leftover term, and we still use it because when something works, don't throw it out just for the sake of trying to be hip. Come on, David. We're old enough. We don't have enough hair. We can't be hip anyway. Though I hear that all the bald stuff is coming back again.
Listen, it's not bald, Shahir. It's getting a little thinner, but in the camera it looks a little thinner than it actually is.
It's shiny, David. It's shiny. Right?
Nice, thank you.
All right. So when we think about tokens, we don't say it's a single token for a person. And the way we talk about it is, you say, let's take 3 fields, simple things such as your first name, your last name, and your date of birth. And your first name and your last name makes you unique to a certain point. For me, it makes you pretty unique. For you, it doesn't. When you add your date of birth, it makes you a little bit more unique. And let's say in New York or in Boston where you live, there may be David Williams born on your birth, that there may be 2 or 3. That's still not unique enough to make sure that there's no mistake. And across Massachusetts, there may be 15. Across the country, there may be 500. So what you want to do is make sure that you add a few more data elements to it. So let's say David Williams with a certain date who lives in a zip code, or at least the first 3 digits of a zip code. Now that gets you a little bit more unique. Let's take, the more you add to the fields, the more unique the person becomes. And then you take that entire string of all those values put together and you run it through a hashing algorithm, a computer-based algorithm that is nearly impossible to break. I'm always careful to say nearly impossible because, somebody with a couple of $1 billion could probably break it, but nearly impossible to break. And then what you do is you say, okay, that is that person's token. But now you have a double problem. Now, finally, I'm sorry I'm making this so geeky here.
I thought we were getting to the solution. Now you got all the way down and I got another problem?
You do.
Okay.
The problem is that the guy who has the data, because is at Mass General, because that's where you got seen for, when you got drunk and fell off the stool and ended up in the emergency room. Oh, wait, we're not supposed to talk about that.
Yeah.
So now you've got this record at Mass General about you. And then you went to your Dr. Jones sitting down the street over at Mount Auburn, and they have a record of you as well. Well, if you let both of those have the same token for David, then somebody is just going to map you back and just say, oh, David is this token, and the token is not any more private than knowing all the information about you. So the way we work it is we make it so that every data set has a different token type. But when permissions are given by the people who are holding the data to put the data set together, a new token is created that does not reflect back on the original 2 tokens, but that makes sure that now David's data from everywhere is put together. Man, I didn't realize I was going to be doing an engineering class.
Yeah,
here.
Got it. No, that was pretty good. Next time we'll have to get you with a little whiteboard or something to make it more self-evident. But I think I got it. All right, so let's talk beyond the mechanics to what can be done with it. Now, you talked about this data consortium that you put together back in April, and I saw a list of different projects that are being done. One that intrigued me was about how individual cities could model kind of when they open and beyond just open or closed, what are some of the parameters that you have there? Can you talk about what that project is and how it uses data?
Right. So first of all, we provided a mechanism for folks to do the research. And then those research projects were vetted by academics, and they said, yep, this is a valid research project. It has to do with COVID, et cetera. Go for it. And there are about 600 some people who have registered, for academics who have registered from 45 different countries, over 100 research teams. One of those research teams is the one that you're talking about. Now, some people have looked at retrospective studies. They've looked at who are the people who are affected, how poor people are affected more by COVID than folks who are well off, how Hispanic and African American communities are affected more than the white folks are, and things like that. But then some people have sort of taken the next step and gone to prospective studies. So this team that came out of a combination of folks from Stanford, University of Chicago, Berkeley, Harvard, et cetera, are all loosely connected economists, computer science, information technologists, medical folks, et cetera, who are all part of a broader umbrella called the National NBER, National Bureau of Economic Research. And they said, look, what if you took all the social information, all the information about education, about health, et cetera, and you put it together and you modeled it at a city level? And they've done it for 5 cities, and they keep expanding it to more cities as they go. They've done it for Chicago, Kansas City, New York City, Sacramento, and I think Houston. Unfortunately, they haven't gotten to Philadelphia, where I have family, or Boston, where you are, or Atlanta, where we have family, but they'll get there.
Yeah.
And what they're doing is they've said, let's take the variables around work. Who can go to the work people? What are the work variables? Essential people, remote people, etc. What is the kind of commercial work that is being done? Can you go inside a restaurant? Can you go inside a store? Or is it just curbside? What have the old elderly folks been told? Stay at home, go walk around, don't worry. what kind of caution methods there are. And they've put all these policies together, and then they've looked at what kind of diseases are being reported, because this database gives you data that is, less than a week old, 3-4 days old in some cases. So we have very real-time data. Plus, they've taken contact information from different places, like information from people's phones that they've made available to say, you can track me, etc. And they've put all that together, and they've said, what would happen if you loosened up Kansas City? What would happen to the level of diseases? What would we expect to happen? So they've done a very good job of prospective work. One last point. This is how science is supposed to work. It's not supposed to be politicized. This is how medicine is supposed to work. This is how science and medicine collaborates together to get things out there, which is you get smart people working with good data that is protected from a privacy standpoint, but still allows them to sort of look at projections. This is what the old CDC was able to do, right? And now we're having to depend on folks to do this independently. Now, these folks used to work with CDC in the past with their data that was available. Now they've had to depend on a private organization making data available for them to be able to do this kind of work. That's kind of the tragedy of what's happened to us. Not that we don't have the data, but that this isn't somehow nicely, coherently planned and managed, right? And I'm really glad that we were able to sort of help out. I just wish that there had been no need for us to do this kind of work.
Well, Shahir, a lot of the models had been criticized, ones that were being used to take a look at hospital capacity and so on. And I think one of the criticisms, they're based on, lots of assumptions and not that much data. It sounds like what you're describing here is allowing rich enough and current enough and relevant enough data sets to be input into a model, and then you can get reasonable results that you can rely on more.
Yeah. Exactly. That's exactly right. Is that what we sort of said, look, what should not be the reason why these models get criticized is the lack of information.
Yeah.
Right. What they should be criticized for, the argument should be about how is the model's method better or worse, not I don't have enough information to plug in here.
And in the case of this model that we've been talking about here about the cities, it can illustrate the trade-offs. That is not in and of itself policymaking, but then you're informing policymakers, and you can have a debate about what is the right kind of a trade-off to make. Where do we want to land?
You really made a really good point there, and I think that's also the point that really applies in business, which is, look, saying that these are the variables that you can change around does not mean that those are the variables that you're saying change these variables. You're saying these are the variables you as a policymaker have to change. That's a lot like how we think about when we're running a business, right? You look at it and you say, I'm not suggesting everything about business is applicable to public policy, but this is one of those times where there is something to be transferred, which is, look, these are the variables that you have to sell your goods in a certain way. You say, hey, I can improve the quality, I can improve on the price, I can get it to market in Indiana, not in Atlanta. I can focus on something, etc. But it lets you have variables that lets you do that. But you use data to make those decisions. You don't just make those decisions and then pray that the data supports what you decided with your gut feel. And gut feel is important, but there's room for expertise in all this stuff that's built on experience and information.
There's also room to analyze data about the microbiome in the gut, but that will be the subject for a different podcast.
It is.
Now,
I'm leaving that one to you. I don't even know what microbiome means.
It sounds small, whatever it is. But Shahir, let's talk about public health. Again, we started off about this. One of the things that I think happens is you have a pandemic, and then people realize, gee, the public health departments are important. And then you always see the data that shows they're underfunded. Funding's been going down over time. And I think we can generally expect that unless there's another overlapping pandemic, that we'll kind of fairly quickly forget about public health and probably not build up the public health departments, at least in the typical way. I also see that, they're burdened right now with kind of antiquated approaches. So when lab testing data is coming in, my understanding is that almost a literal avalanche of faxes is coming in, to public health departments. Is there an opportunity with these new forms of data and ways of managing them and with interoperability that public health really can leverage data and do it with maybe reasonable budgets and without tons of people? And we might actually improve our public health infrastructure without massive new funding?
Well, I mean, those are three questions. So let me see if I can parse them a little bit. The first one is, can automation improve the process that's there? And I believe that technology through automation based on technology can absolutely do that. That does not mean that we have to throw away our faxes, et cetera, mechanism. But technologists have always started with the idea of, let me automate what is going on and then build on top of it to make it better. Look, I grew up in the logistics industry. Testing is not a medical problem. It's a logistics problem, candidly. It is about how to get the test and the person who's supposed to be tested meet at the same place and to take a snapshot of it. The only problem with this testing issue is that it's retrospective. It only tells you what has happened in the past. You're not affected as of now. It doesn't tell you how good it is in the future. You'll be affected tomorrow. And the idea here is, the problem then is that you have to repeat it over and over again. So the first thing you have to do is get good at automation. Why? Because automation is what makes it possible for you to do things repeatedly cheaper, right? And fast and more reliably. So let's get automation into this process. And a lot of people have spent a fair bit of time thinking about how to get that right. There are really strong interoperability standards that are coming in that lay on top of it, which is the second problem. Now that I have the automation done, how do I make it so that I can exchange that information, get that test to the doctor faster, have it stick inside the EMR without having the person have to go in and retype it? We don't need more folks taking a piece of paper and typing in something that came from one computer back into another computer. That should be automated. So interoperability is the next layer above automation, if you think about it. And that challenge it's very important, and it's made worse in the United States because of our fragmentation. For a lot of good reasons, we have said that we want a competitive healthcare system, but a competition also means that there are a lot of players. There's hundreds of people generating data at the healthcare point of care, and that means that all those things have to agree on an interoperability standard. Can that be done? Well, of course it can, because we have thousands of manufacturers of cell phones, and yet cell phone, I can call you, you can call me without having to go through all kinds of craziness. We don't have to have a central switch and say to somebody, could you get me Cincinnati 4, 5, 6, 7, 8 or something like that anymore. We've automated that process and we've made it interoperable. Those are the two first must-dos. Now, the third one is, can we do it cheaper? Well, probably. In the long run, if you add up 20 years of costs, I guarantee you, I would stand by this, that 20 years of cost in an automated, interoperable environment that has a centrally usable, intelligent database that we can do planning around is cheaper than the manual processes that are happening right now over the same 20-year horizon. Quite possibly it's a 10-year horizon. But it's certainly not over the next 3 years. Over the next 3 years, I guarantee you we're going to spend a lot more money to do automation and interoperability, just as we had to spend a lot of money after the Department of Homeland Security got put in to make sure that we were safe after 9/11. But now, candidly, dollar for dollar, I think we're safer than we were in 1999. And I think dollar for dollar, we can be safer in 2030 than we are in 2020 against pandemics. So to me, it's a question of investment and return.
So Shahir, we started off with some kind of personal questions, and I want to, that's sort of about your early upbringing up till age 17. Now I want to go and talk about what you're doing now. Assuming you have time to read, I know you read a lot of like software manuals and that kind of thing, but any interesting, any fiction, any interesting books that you're reading?
Well, so I want to first put the software manual thing to rest. The thing about engineers, David, is that we're only our half-life is about 5 years. I think Lester Thoreau said that. The half-life of an MIT engineer is 5 years, and so I'm way past that 5-year mark. So I'm like a 1/20th of 1% now. So I do read nonfiction, but I read nonfiction that is to make me a better citizen. The nonfiction I've been reading lately is actually called the what is it called? The Fifth Risk by Michael Lewis, which is about how a lack of good planning in the transition process for the presidency is kind of a reason for a lot of the problems we're facing now. Is there's just, if you don't build a good plan, you don't build a good execution. So it's made me take notice, and I've sort of doing the only political thing I'm doing this year actually is to make sure that the presidential transition team, in case and when Vice President Biden becomes President Biden, that we should be prepared for it. So I'm trying to raise money to help do that, and I'm waiting for your check, by the way. And but on
now that you got my name and zip code, it's probably just a matter of you could just probably suck it out of my account directly.
Why don't you just send me your ABA routing code and your checking account number? We'll take care of the rest.
Yeah.
But on the fiction side, I will say just to prolong this answer a little bit, I'm notorious about not reading fiction, but my wife is fantastic at this. So we drove to California in an RV to go spend some time with the grandchildren. And she said, look, I've read these great books in the past. You'll enjoy it. So when we were driving out, we listened to American Gods by Neil Gaiman, which blends a bunch of Americana and fantasy and a bunch of old and new mythology with the idea of what happens to, and the question he asks is, what happens to those deities when we stop believing in them? And then on the way back from California, after 2.5 months of staying there, we listened to Seven Eves by Neil Stevenson, which is about how does humanity react after the moon blows up and the debris rains fire on Earth and kills everybody except for a few hundred people who are hastily relocated to space stations. So, really pleasant, fun
That's
reading.
a real escape from the realities of the pandemic, huh?
Exactly. So, I think there's a theme in my life. Worry about things and worry about and figure out how to deal with some problems in the short run. That's sort of the common theme in my life.
Shahir, it's been great to have kind of a world tour, and I guess we got as far as the moon, which exceeded my expectations for the podcast today. A lot of great topics, and look forward to following up on all the interesting work that you're doing, including I want to follow up maybe on that city reopening once they get to Philly and Boston and so on. So maybe we can have that as a follow up.
Absolutely. I'll make sure that those folks are in touch with you. That'd be great.
Excellent. You've been listening to the Health Biz Podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.